Endocrine neoplasia type 2 or MEN2 is an autosomal dominant disease. It is divided broadly into two categories, namely MEN2A and MEN2B, and MEN2A accounts for 95% of the cases for MEN2. In MEN2A syndrome, almost all patients develop medullary thyroid carcinoma. This is followed by pheochromocytoma, which develops in around 50% of the patient. And a MEN2A syndrome is further divided into four subtypes. So let's go to our topic today. This is about pheos in MEN2A patients. Pheos are rarely the initial manifestation in MEN2A. In this era, it is usually detected from screening in patients with known MEN2A mutations. They are less likely malignant when compared to sporadic pheochromocytoma. Moreover, they have a variable penetrance depending on which specific red germline mutation the patient carries. For example, codon 634 mutations would have a high penetrance of pheochromocytoma. Interestingly, pheos in MEN2A patients are often bilateral with a report of 30% or more. And for patients with unilateral pheos, they often develop the contralateral pheo in the contralateral gland in the next 10 years. This study illustrated how the penetrance of bilateral pheochromocytoma is affected by different kinds of mutation. As you can see on this diagram, patients with codon 634R mutation have higher penetrance of bilateral pheochromocytoma at all ages than the other codon 634 mutations. Moreover, the penetrance of bilateral pheos increases with age. It is therefore important to know about which exact mutation the patient carries, because this would have prognostic and also management implications. So, what are the possible surgical approaches to patients with pheo in MEN2A syndrome? It depends on how the patient presents. They can present initially with a unilateral pheo, or they can present with a bilateral pheo on initial presentation. The options for initially unilateral pheos would be either a unilateral adrenalectomy or a more radical approach of a preemptive bilateral total adrenalectomy. So let's first talk about those patients with unilateral pheos. The most important step first is to confirm whether it is a unilateral disease first. We can do this by a CT or MRI scan, or more commonly, functional imaging with MIBG scan or F-Dopa PET scan or a gallium dotatate PET scan is preferred. This may reveal some small lesions which cannot be detected in an axial imaging. What about the less radical unilateral adrenalectomy approach? There seem to be more advantages and seems to be more logical. The argument for this approach would be that not all patients develop a contralateral pheo. And even if the patient develops a contralateral pheo, we can do a partial adrenalectomy for this contralateral pheo, which could still preserve some of the adrenal function, as opposed to the preemptive bilateral adrenalectomy, in which all the adrenal function would be gone. Also, there's a long time interval before patients develop a contralateral pheo, and in between, the patient would be drug-free, and there's no risk of having an Addisonian crisis in this period. Moreover, we know that the pheos in MEN2A are less likely malignant. The cons for unilateral approach is, of course, the patients may need a second surgery if they develop a contralateral pheo. So in general, the consensus is that a unilateral adrenalectomy is advised for patients who present with only a unilateral pheo for MEN2A. This is followed by long-term postoperative surveillance for any development of a contralateral pheo by urine or plasma test. Of course, this approach has to be tailor-made. For example, for patients with a strong family history of bilateral aggressive pheochromocytoma, a more aggressive approach of preemptive bilateral adrenalectomy might be warranted if they already have a unilateral pheo. What about for patients with bilateral pheo? The options would be either a bilateral total adrenalectomy or a partial cortical-sparing adrenalectomy. In the year 2014, the Endocrine Society published a clinical practice guideline which suggests patients who are having hereditary pheochromocytoma who already had a contralateral complete adrenalectomy to have a partial adrenalectomy for a contralateral pheochromocytoma. The rationale behind is that this approach could achieve a very high steroid independence rate of up to 90%. However, there's a risk of recurrence in 38% of the patients. What about more recent evidence? In this study published in 2019, 625 patients with bilateral pheochromocytoma were included. More than half of the cohort were MEN2A patients, and this study compared the outcomes of cortical-sparing adrenalectomy versus that of bilateral total adrenalectomy. The median follow-up time was 8 years. So from this table, you can see that for cortical-sparing adrenalectomy, the rate of adrenal insufficiency is quite low. So more than 70% of the patients are steroid-free. The rate of recurrent pheo is 13%, which is lower than the 38% suggested by the previous guideline. And more importantly, the rate of metastasis is not significantly different from that of a total adrenalectomy approach. And there is also no impact on overall survival. Moreover, for the patients who became steroid dependent, at least 18% of them developed at least one Addisonian crisis, and 13% of them developed iatrogenic Cushing syndrome. So, with the low rate of metastasis and with the no significant impact on survival, together with acceptable recurrence rate, it seems that cortical-sparing adrenalectomy is the current trend for bilateral pheochromocytoma in MEN2 patients. So, what are the selection criteria for a successful cortical-sparing adrenalectomy? Most of the authors in the literature agree that a small single tumor of less than 3 centimeters would be favorable. A typical margin of 2 to 5 millimeters is recommended. For laterally located tumors, it is usually easier to preserve the central adrenal vein. Whereas for medially located tumors, very often the central vein has to be sacrificed. 20 to 50% of the remnant volume is recommended to preserve the cortical function of the adrenal. This is a diagram illustrating how the location of the adrenal tumor would affect the preservation of the adrenal vein. You can see in patient 5, in the right lower corner here, the tumors were located more far away from the adrenal vein, more laterally or more superiorly, and therefore the surgeon was able to preserve the adrenal vein. Preservation of the adrenal vein has the advantage of retaining more adrenal cortical function, even with a smaller remnant. So in other patients, the tumors were closer to the adrenal vein. and therefore the adrenal vein has to be compromised. There have been different techniques for transection of the adrenal parenchyma, namely the use of energy devices, clips, stapler, argon beam for hemostasis, and also fibrin glue. And all the approaches applied for total adrenalectomy can be applied for partial adrenalectomy, namely the open approach, laparoscopic approach, retroperitoneoscopic approach, and the robotic approach. And recently there have been reports of the use of ICG. Indocyanine green has emerged recently as a promising technique to aid dissection in partial adrenalectomy. It involves intraoperative injection of ICG, in which the adrenal and the retroperitoneal tissue would uptake the ICG dye in around 1 minute. And then there will be a rapid washout of ICG away from the retroperitoneal tissue. This would outline a hyperfluorescent adrenal gland. There are reports on the identification of pheochromocytoma with ICG during partial adrenalectomy, and it is also helpful in the evaluation of the vascularity of the remnant. In this study published in 2018, where there were 100 robotic partial adrenalectomies done together with ICG, there were 59 cortical tumors. 95% of them were hyperfluorescent, whereas for the 24 medullary tumors, which are pheochromocytomas, 67% of them were non-fluorescent. The authors suggest that for large fields that penetrate through the adrenal cortex, they would appear non-fluorescent because the adrenal medulla is typically non-fluorescent from their observation. In this case, ICG would be useful, since it would show up a line of demarcation for transection. Whereas for small pheochromocytomas covered by the adrenal cortex, in ICG imaging mode, it would appear hetero or hyperfluorescent because of the adrenal cortex wrapping around the tumor. In this case, ICG would not be that helpful. Moreover, background liver fluorescence may cause interference, especially for right adrenalectomy during the posterior retroperitoneal approach, and therefore the authors recommend ICG use for the transabdominal approach only. This is an example taken from a study published in 2020. On the picture on the right side, you can see that the normal adrenal cortex appears hyperfluorescent or blue under ICG imaging, whereas the pheochromocytoma appears non-fluorescent. The surgeon can then do the transection along this line of demarcation. In summary, bilateral pheochromocytomas are common in MEN2A patients. The risk of bilateral pheos increases with age in MEN2A, particularly in certain mutations. Partial or cortical-sparing adrenalectomy is the current trend for bilateral pheos in MEN2A patients, because if the patient undergoes total bilateral adrenalectomy, the associated possible adenosine crisis could be life-threatening. Moreover, pheos are currently rarely the cause of death of MEN2A, thanks to the advancing technology and also the tight screening program. Partial adrenalectomy also achieved a high steroid independence rate, and also the pheos in MEN2A have a low malignancy rate. There's also no impact on survival for this partial adrenalectomy approach. Finally, there are evolving technologies to aid partial adrenalectomy, namely the indocyanine green technique. Thank you very much.